This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Neuro-Oncology, published in 2026. It's titled Laser Interstitial Thermal Therapy versus Stereotactic Radiosurgery for First-Time Treatment of Recurrent Glioblastoma, a retrospective single-center study.
This is a topic that hits home for all of us in the field. As we know, despite our best multimodal therapies, glioblastomas invariably recur. It's one of the most aggressive primary malignant brain tumors we face, and even with the STEP protocol, maximal safe surgical resection followed by chemoradiotherapy, the 5-year survival rate remains a sobering 6.8%.
Exactly, Dr. Eris. And once we hit that point of recurrence, the management becomes a real clinical challenge. There's no single therapeutic modality proven in randomized trials to significantly prolong overall survival at that stage. We're often balancing local tumor control with the need to preserve neurological function in patients who have already been through the ringer with previous treatments.
Which brings us to the two minimally invasive salvage strategies discussed in this paper, Laser Interstitial Thermal Therapy, or LITT, and Stereotactic Radiosurgery, known as SRS. Both aim for focal cytoablation or cytotoxicity while sparing the surrounding brain, but they go about it very differently.
Right. LITT uses MRI-guided thermal ablation to destroy tissue, traditionally used for those deep-seated or surgically inaccessible tumors. SRS, on the other hand, delivers highly focused radiation. The authors of this study, Bindal and colleagues from the University of Texas at Houston, noted that while both are used, there's a real lack of direct comparative evidence to guide us in choosing one over the other.
What I found particularly interesting about their methodology was the focus on cohort homogeneity. Many previous studies on RGBM lump everyone together, patients at their first recurrence, third recurrence, and they often ignore IDH status.
That's a great point. This study specifically looked at 57 patients treated between 2010 and 2025. All of them had glioblastoma, IDH wild type, per the 2021 WHO classification, and they were all being treated for their first recurrence.
Let's dive into those results. They had 10 patients in the LITT cohort and 47 in the SRS cohort. Ilara, what did the survival data show?
The primary endpoint was post-recurrent survival, or PRS. For the LITT group, the median PRS was 11.5 months. For the SRS group, it was 13.4 months. When they ran the univariable log-rank tests, the p-value was 0.824.
So, statistically speaking, no significant difference in survival outcomes between the two modalities. That's a crucial finding for residents to note. Both options provided roughly a year of survival after the first recurrence in this specific IDH wild-type population.
But there was a major difference in the baseline characteristics that we have to discuss: tumor volume. The contrast-enhancing tumor volume at recurrence was significantly larger in the LITT cohort, 8.49 cubic centimeters compared to just 1.91 cubic centimeters in the SRS group. That gave a p-value of 0.007.
That makes clinical sense. In practice, we often lean toward LITT for slightly larger masses where we want an immediate cytoreductive effect, whereas SRS is typically reserved for very small, focal spots where the radiation drop-off can be tightly controlled. But because that volume difference could be a major confounder, how did the authors address it?
They used propensity score matching, or PSM. They were able to match 2 cohorts of 7 patients each to account for those confounders. Even after matching, the results held firm. There was still no significant difference in survival.
Let's talk about safety, because that's often the deciding factor when survival is equal. What did the study find regarding complications?
This was a win for both, but with some nuance. In the LITT cohort, there were 0 surgical complications. In the SRS cohort, they reported 2 cases of symptomatic radiation necrosis, which is about 4.3%. While the p-value for that comparison was 1,000, meaning not statistically significant in the sample size, it's a clinical consideration. Radiation necrosis can be a difficult beast to manage in an already compromised patient.
It certainly can. And it's worth noting that LITT is sometimes actually used to treat radiation necrosis, so seeing 0 complications in the LITT group for primary recurrence treatment is encouraging for its safety profile.
The authors also mentioned that management of RGBM requires balancing tumor control with ongoing chemoradiotherapy. Reoperation is often limited by the patient's condition or the location of the tumor. LITT and SRS both fill that gap for minimally invasive options.
For the residents listening, it's important to remember the mechanism. LITT is MRI-guided thermal ablation. You're seeing the cook happen in real time with thermal maps. SRS is highly focused radiation aiming for cytotoxicity. The paper suggests that for small, focal RGBM, both are viable salvage options.
Dr. Aris, based on this paper, do you think we should be favoring one over the other?
Well, the study concludes that within the limitations of its small sample size, the outcomes are comparable. However, the fact that LITT was used for tumors nearly 4 times the size of those treated with SRS and still achieved similar survival is quite interesting. It suggests LITT might have a broader range for focal recurrences that are perhaps a bit too large for ideal SRS dosing.
Right, and the authors are very transparent that this was a single-center retrospective study. They are calling for larger multi-institutional studies to really firm up these conclusions. But for now, it gives us confidence that if a patient is a candidate for either, we are offering reasonable alternatives.
And for those medical students preparing for rounds, remember the key takeaways from Bindal et al. 2026 data, median post-recurrent survival is around 11 to 13 months, and when it comes to LITT versus SRS for IDH wild-type first recurrence, the survival data is largely equivalent.
It's also worth noting the timeframe. This study looked at patients up to 2025, which reflects our most modern surgical and radiotherapeutic techniques.
Exactly. It keeps us current. I think that covers the deep dive into this comparison. It's a short but impactful study that clarifies some of our salvage strategy questions.
Definitely. It's all about having more tools in the shed for a disease that is notoriously difficult to treat.
Well said. That's all the time we have for today's episode. I'm Dr. Aris.
And I'm Dr. Alara. Thanks for joining us on the Neurosurgery Hub podcast. We'll see you in the next one.
Keep learning, and we'll see you in the OR.